Уважаемые коллеги, позвольте нам начать секцию. Все вы хорошо знаете, что несколько лет назад был организован Vein and Lymphatic University. Председателем которого является наш хороший друг Ловел Кабник, сопредседателем Виктор Каната из Парагвая. Они были здесь у нас пару лет назад и активно участвовали в Санкт-Петербургском венозном форуме. Вы всех видели, задавали вопросы. Значит, Vein and Lymphatic University сейчас охватывает около 1000, наверное, человек по всему миру, и это помимо там семинаров, практики, в основном онлайн-мероприятия, которые позволяют обмениваться опытом, знаниями, какими-то презентациями пациентов. Во всем мире активная дискуссия такая идет. То есть достаточно необычный формат, но он очень активный, пользуется популярностью и постоянно увеличивается. Сегодня мы вместе с нашими коллегами приняли решение провести такую достаточно быструю секцию, учитывая наше плотное расписание. Значит, в течение часа мы обсудим те насущные проблемы, которые сейчас на пике наших технологий, на пике наших дискуссий в разных странах, на разных континентах. Поэтому я так думаю, что это будет и, естественно, является актуальным для нас, и мы обсуждаем это в течение наших секций, поэтому это будет такое хорошее дополнение. Значит, у нас в президиуме Денис Александрович Барсук и Елена Леонидовна Мурзина, которые являются членами президиума Vein and Lymphatic University, Совета директоров. Да? My dear colleagues, morning for you, morning. We started yesterday and very active 17th St. Petersburg Venus Forum. This year we organized it together with Kazakhstan Society of Phlebologists, Uzbekistan Society of Phlebologists, and Society of Phlebologists, our colleagues and geologists in Belarus. So about 600 participants. Today is the second day. So we are ready to start. Very important for all the world, Vein and Lymphatic University. And I can see my fantastic friends. And we are ready to start. Hello. Hello.
I'd like to take having a Vein and Lymphatic University session at the prestigious St. Peter. VLU is a voluntary group of faculty, as you mentioned, from all across the world, over having about 3,000 faculty, but on WhatsApp, 1,005, with an interactive program. This mission is to teach our students and colleagues improve patient outcomes. In addition, I would like to thank our honorary chair, presidents, moderators. Evgeny, if the program.
Yes.
Thank you.
Thank you. Thank you very much, my dear friends. And we are ready to start. Yes. And our first presentation from Paraguay, from our dear friends Victor Kanata. What is the porcupine technique for varicose veins? And we have two discussants, Ashat Sharipov and Denis Barsuk. This is the technique дикобраз. Please, Victor.
Good evening to all my friends of St. Petersburg Venus Forum. Thank you very much to Dr. Shai and all the Russian committee who let me give this special presentation, as also to the VLU Chancellor, Dr. Lowell Kapnik, who gave me that task to have this presentation. I will talk today about total endovenous laser ablation and what is the porcupine treatment. I don't have conflict of interest, and the final problem is what is porcupine treatment? As you see in these last years, we start seeing too many pictures like this with so many needles applying through the skin and below the knee, above the knee, over the leg, over the one side, over the other side of the leg, with too many avocaps inserted in the leg of the patient under sonographic guidance. When we saw this, we were just really asking, this is really good for the patient? This is really will cure the varicose vein disease? It's a new technique, and there are a lot of people who start asking about that, and this is my final presentation today, trying to show what is going on and what's happened with this new technique that we call them porcupine. You see, there is needles in the thigh, there are needles in the back of the leg, in front of the leg, with so many approaching under local anesthesia and the ultrasound guidance. And so we know superficial venous insufficiency of the lower limb is considered a multifocal refluxive disease. There's no way to have an accurate treatment without mastering the sonogram and excellent venous mapping. The technique consists of the treatment of the trunk and the tributaries with endolaser. As you see right now, you are seeing two videos of the technique. There are so many avocats inserted over the leg of the patient, all of them with blood inside, showing that the puncture was accurate and the vein was treated. Also, since 4 or 5 years, we start seeing this picture over the internet with that crazy marking done by Michael Fraffer in French. You see those numbers with all over the leg with different piece of paper writing inside of the leg, who show also at the end a very good result. You see here before and after, seeing that something is happening. He was treating the vein under ultrasound guidance with some new kind of catheter that he developed for the treatment, with this strange market with watts, numbers, different size and texture of the patient, just to give an accurate result of the treatment. Why do we call them porcupine? Porcupine is because they do, as we know, so many punctures in the skin. It's an ambulatory treatment. There are new materials, there are new fibers. It's local in office, less complication with a carry-on post-operative that is relatively good without no pain for the patient. The new kind of fibers are changed. We have single ring laser fiber, double ring laser fiber, infinite rings, bar fiber, and carbonic fibers are new kind of stuff that we are coming with the changing in wave of the laser from 810 to 1940 that is recently given to you as a very good result with best problem for the patient. What are the requirements? The requirements are ultrasound, a specific skin marking, a very good cartography, mastering the introducer with the avocap, who use 14, 16, 18, and 20 gauge avocat, guide of the catheter over the tortuosities of the vein, local anesthesia, fire the laser, and then you will have the result. Look at this. This is a mapping previous of the treatment with how many areas I will be doing the treatment and the setting that I prefer. The preferred fiber is usually the rider, but they usually use the bar fiber, 400, 600 bar fiber, ultrasound guided ablation, and 4 to 6 watt with a 1740 or a 1940 laser emission machine. You can see over there, you see how many punctures that we do and how many situations that we have. One of the masters of this also is Dr. Daniel Matusi in Brazil, who has the first written treatment already. They call them ATA, ablation total assisted. And you can see here, he's puncturing the skin so many times, and he's, after this, giving local anesthesia to the patient. Another one from Brazil is Dr. Nara Medeiros, who called the technique theta, transfixing the venous thermal ablation. And you see also over there, he's using an avocad going to the collateral of the vein, trying to puncture the vein, get access, get refluxing, and then he add the laser beam with the rider fiber and using it without big trouble. What are the advantages of the theta technique? You can associate with other techniques. It's easy to execute, has shorter surgical time, and they have less bruising and phlebitis with the other one. Also, he is using augmented reality to get the access of the vein. You can see over here, the results are excellent and the patients are very happy. Also, in Vena Clinic from Poland and Dr. Piotr Marciniuk and Dr. Jan Stepanski in Poland are having the same. You can see the lady with a huge varicose veins with so many catheters inside, and then the results are excellent. What is the idea of this technique? This technique allows us to cure all the veins, all the collateral. It's feasible for all the varicose veins. You don't use a guide wire. It's simple and fast. It's not very aggressive. And also you can use the normal avocad that we use for venous access just to fix the patient. You can see here a short one with not too many avocados, and that one shows the central who is going to the large saphenous vein that will be going through trying to fix the vein. Also that one that you can see here is showing that under sonogram you are able just to puncture the vein and go through without trouble. This technique allows us the treatment of varicose veins, the gray saphenous vein, the small saphenous vein, the anterior saphenous vein, and the tributaries. Puncture of the vein, introduction of the laser fiber, local anesthesia perivenous, application of the linear endovenous laser energy density, and then after the introducer are in place, tilt the table to turn the lumbar, and then tie the vein and have better contact with the fiber, and then use the local tumescent anesthesia under zone to protect the skin. Then you will be able just to fix the patient. Dr. Michael Froffer used that kind of technique. You see over here, the skin marking specify all introductory points. The length of the varicose vein to be treated, the graduation of the laser fiber, introduced at the withdrawal, position of nerve to be separated by tumescence, the powering was to be 5 and the lead in Joule. See over here, you can see 7 watt, you can see 8 watt, you can see 50, the market 50, 60, 70, and 80, and this is the length of the vein to be treated. Meaning that they have a very good structure map and they have very good results. Now, at the end, you see the paperwork saying that the technique is good and will give us very good results without very good trouble. What will be the future of the varicose vein treatment is the end. And the end, we start so many years ago with the stripping, then we do phlebectomies, then we do crossectomy, then we strip all the veins for the patient, then we start using the laser, then porcupine appeared, and then we saw that the evolving world of phlebology is really great. And we are having so many meetings all over the world trying to improve the technique that will be improve the outcome of the patient. And this is the final idea of Vein University, the St. Petersburg Vein Forum, and all the team that is related to varicose vein disease. I have to say thank you very much for the opportunity, and I'm going to the floor just to make sure that everything is fine, and I want to take questions. Thanks, my friend, and see you soon.
Thank you very much, Victor. We have one discutant and some discutant from our audience, and discutant Askhad Sharipov from Kazakhstan. Please, Askhad.
Хочу поблагодарить Евгения Владимировича Шайдакова, доктора Ловола Кабника и профессора Канату за возможность быть представленным на этой секции. So I would like to share my opinion. I use it in cases where there are not very tortuous veins, tributaries or venous tributaries with slight tortuosity. I prefer to use so to speak the subtotal endovenous laser ablation option for recurrent varicose veins or veins with post-inflammatory changes in the venous wall, or if sclerotherapy was previously performed. For a primary procedure with highly tortuous venous tributaries after truncal ablation, usually I use to perform a mini phlebotomy. There is some amount of post-procedure pigmentation present. I think so. My question to Professor Kanata, in your experience, what technical tricks and tips help reduce or avoid hyperpigmentation? Yeah? More energy, valve length, or fiber type, please?
Victor?
Okay, I think the best approach is usually trying to be in the vein, try to use the less amount of energy that you can and protect the skin with your local anesthesia. You will have anyway induration, you will have some kind of inflammatory reaction, but it will go down if you do use the amount of energy that you deliver it to the skin and to the vein in a small amount, and so like a 2 or 3 small puncture after you do the treatment. And this will be the tip and trick for the treatment. It's feasible, you can do it, and there are a lot of people that are improving the technique right now, trying to fix everything.
Thank you very much, Victor. From our audience, Denis Barsuk.
Dear colleagues, so honestly, I'm so happy to see all of you here. And nowadays we have such a high audience from all over the world, and I think it's fantastic, and I'm so happy to see you here. So my comment will be about this procedure in the way of, so we still do not have a comparative studies with microphlebectomy. I suppose that such a high professional people as our friend Dr. Victor Kanata can make this procedure in the best ways, like a private suit, you know, which you can order. But so, in having said about this procedure, for all of our people in the audience, we still need to have some comparative studies with microphlebectomy, I suppose. So, Victor, it's a great, way for us, and it's very interesting. I suppose it can have some perfect results. But not all of us is such a high experative, person as you. So let's move forward. Go ahead with such a way, have some comparative studies and evidence-based medicine in this field. So, and I hope that in the nearest future we will have some results from comparative studies. So this is my comment, and I want to say again that I'm so happy to see you, all of you here. I don't want to say all of your names, that we have a very close friendship and with most of them, for you. So, and it's very great pleasure to see all of you here. Thank you again. And I give a word to Professor Shaidakov, the president of our meeting.
Thank you very much. Thank you very much, Victor, again, for fantastic presentation, and for Denis and Askhad. And please, Kathleen.
Good morning or afternoon, everyone, and happy Thanksgiving to those of you who celebrate.
I'd like to present our next speaker, The Principles of Stenting in Iliofemoral DVT by Professor Human Jali. Please take it over.
Thank you very much, dear Kathleen, for the kind introduction. Many thanks to the organizer, to Victor and Laura for inviting me. I'm going to share my presentation now. I hope you can see it soon. Sorry. Can you see my presentation?
Yes.
Okay, perfect. Let me start it. Okay. So my topic is principles of stenting in iliofemoral DVT, and I have 6 minutes to go, so I cannot address all aspects of the stenting. But maybe because it is DVT and not chronic venous obstruction, I would like to focus on landing zones. That means if we have an iliofemoral DVT and we treat the DVT with percutaneous mechanical thrombectomy or catheter-directed thrombolysis, or both, and the thrombus is removed, what should we do with the underlying disease and how should we stent? This is my disclosure. Is the slide changing or not?
Yes.
Okay, perfect. Thank you very much. It's my disclosure. So, I am talking about these kind of pathologies. You see on the left side, acute descending iliofemoral DVT. I hope the movie is running. And you see a lot of collaterals and the thrombus involving the entire iliac tract. And after percutaneous mechanical thrombectomy, here in this case, I think that was after few runs. And then we went for 1 day of echoslysis. And then you can see the underlying disease, mainly involving the common iliac vein. And believe me, in that case, it was a nivel, a materna, with some post-thrombotic changes also farther distal. So how should we stent it? Another case here, acute descending iliofemoral DVT. You can see the inflow is good, the common femoral is good. You see a lot of collaterals. You see the distal tip or tail of the thrombus, and it's involving the entire iliac tract. After GEDI thrombectomy, percutaneous mechanical thrombectomy after 3-4 runs, and that is what has been demasked as underlying disease as the nivel. So how should we stent them? Very important is what should be taken in consideration while we are going to stent them. Very important is a migration. I think not even one migration should happen, as many of those patients are young. Many of those are young ladies and otherwise healthy. And if it lead to an sternotomia or to the death of patient, even 1 to 500, 1 to 1,000 is too much. So migration should be prevented 100%. A jailing should be prevented, like in this case, or in the second case, you see a dedicated venous stent is in place, but jail the contralateral side totally. Despite porosity of the stent, the contralateral side developed a DVT. We have also to prevent something like this. This is a short stenting. The stent ends just before the artery. So it's a nonsense to put a stent while we are not treating the maximal point of the compression, or here in this case, you see the stent is absolutely too short. So here are the landing zones we need. We have to determine very carefully the proximal landing zone after treatment of the DVT and the distal landing zone, normally in those cases, somewhere in external iliac vein, because normally we need 1 stent. In some cases, maybe 2 stents. How should we do it? 100% IVUS should be used. Why? First, with IVUS, you can see if you clean the vein properly. So we know the clean vein hypothesis. The cleaner the vein, the better the outcome, the less PTS the patient will develop. So first, with the IVUS, you can see if it is clean or not. And very important is while we are doing the IVUS, we can go on live, push it, pull it, few times and see exactly the border of the overriding artery. So the common iliac artery is going over the vein, over the confluence, and with the IVUS you can exactly determine, like here, you see this is the beginning and this is the end of the maximal point, and you can exactly mark it on the monitor. Then we put a crossover pull-back phlebo from the same introducer sheet. You take another wire with a catheter, go crossover, pull back, and give a dye. With that, you can exactly visualize the confluence. So with the IVUS and with the phlebo, you have a perfect visualization of that, what you need. You know the maximal point of the compression, you need the IVC borders, and with that, you can place your stent perfectly. And of course, using a dedicated venous stent. Here, a case we did exactly like that. We draw it on the monitor. This is the proximal border of the artery. This is the borders of the confluence. And you see how exactly this stent has been deployed, precisely chosen proximal landing zone, preventing a contralateral jailing. So we jailed probably 40%, but not 100%. So 2024, ladies and gentlemen, you should not rely on bony landmarks. You have IVUS, you have phlebogram. Combining those two, you have the perfect landing zone. And of course, also the distal landing zone is very important, because if you treat the DVT, we are not talking about PTS patients. We are talking about otherwise healthy veins, endothelium. And if you miss maybe the May-Turner point, the stent can migrate. So take longer stents, big stents in size, but also longer. The distal landing zone should be somewhere in the middle of the external iliac vein with a good alignment, preventing migration. This is the same patient on the post-op duplex evaluation, and have a look here how precisely the stent was deployed below the maximal point of the compression. Another patient with short proximal stent landing zone has been referred to us because the patient was still on the had the complaints, and they didn't know why. We did a CT, and also with duplex you could see the stent is too short, so the artery somehow is still compressing at that point. And this again, we went for a pull back crossover phlebo. We did IVUS, and with the help of IVUS and pull back phlebo, we visualized the perfect proximal landing zone. And in that case, we took a sinus oblique with an oblique shape in order to prevent 100% the contralateral side. So does an oblique shape matter? I think there are some anatomies in those oblique shape matter. This is when the angle of the confluence is short, small. It is advantageous, I think. Just have a look here. This is the contralateral side, the contralateral iliac tract. This is a normal non-oblique stent, which also I use. Please use only dedicated stent like Abre, Vinovo, Beyond, or Sinus Venous. And you see we have to jail in this case with the stent 80%, 90%. But if we would have taken an oblique shape, that would be the result. Maybe only 20% jail. Whether that could be translated one-to-one to the clinic, I do not know, but it makes sense in the short angle confluence to take an oblique shape. So in summary, ladies and gentlemen, after treatment of acute iliofemoral DVT, the cleaner, the better. The underlying disease should be sufficiently addressed. So our regime is not to wait and see what happens again. Correct visualization of the confluence, not bony landmarks, and determination of landing zones, proximal and distal, is mandatory, and it leads to a perfect result. And of course, correct sizing of the stent. So if you think you are between 14 and 16, take 16. I think with 14 and 16, you can address all sizes, maybe very huge patients, you need 18. And you need a long stent in order to prevent migration. The distal landing zone should be external iliac vein. Thank you very much.
Human, that was an excellent talk, as your talks always are. I learned from you so much. I have a couple of questions for you. Number one, what do you do when the inflow is terrible? So in other words, when the femoral vein is not good, because as we know, when the inflow is bad, no matter how nicely you place the stent, that's an issue. And then my second question for you, I noticed on the images there that one of the patients had been treated with coil embolization. How do you time the coil embolization with the placement of the stent? And do you always look at the common iliac vein at the time of coil embolization? I'll stop there.
Thank you very much, Kathleen, for those nice questions, important questions. First, bad inflow, but let us categorize. We are talking about DVT, bad inflow in DVT patients, and not bad inflow in chronic venous obstruction patients, because the topic is now DVT. Yes, then we are talking about ascending thrombosis. So that means patients normally without underlying disease, without anatomical underlying disease, but more with hemostasiological underlying disease like thrombophilia or other hypercoagulable states. If I did maybe 7-8 cases with clot trigger, perfect results with many runs, and the results really showed a clean common femoral vein, clean iliac tract, but there was no inflow. All of them went down, all, not even one stays patent. So you have to do something for the inflow. In those cases, either if they are in the first 2 weeks, I go with other catheters like JEDI, which is very flexible. So I do the thrombectomy, transpopliteal, but then I go crossover or from jugular approach and clean at least the main tributary of the deep femoral vein. Better you give also a local lysis. Or I do my thrombectomy, let us say with clot river, JEDI, or anything else, and then I put a catheter-directed thrombolysis for 1 day in order to clean the inflow. Otherwise, it is a nonsense to do it. It will occlude. The second question was timing. I think you mean a pelvic venous disorder patient, lady, with maybe pelvic disorders like this patient and compression and nutcracker and those things. I would say I have learned from my friends like you, Ram, Alex. So concentrate on symptoms and not just thinking in those patients physically like us vascular surgeons, because we think if there is a compression as a nutcracker, that has to be addressed first. Otherwise, all veins will be dilated and there is no drain of the vein. This is not correct. If a patient comes to you and the symptoms are flank pain, heavy flank pain over years, microhematuria, proteinuria, then I address the nutcracker. And today my approach is open and not standing anymore. If the patient is there with a heavy compression as nutcracker phenomenon, but not flank pain, I address the smaller approach, which is bottom up, and instead of top down. So I start, if the leg is varicose veins, I treat the varicose veins. If the pelvic vein is leading the symptoms, I coil the pelvic vein. If I am in the OR, in the phlebogram, I always with IVUS check, of course, the nivel point. Not in order to decide to put a stent, but I check it always.
Thank you so much for those insightful comments. And just very quickly, what is your anticoagulation protocol?
In acute DVT, as all you know regarding the DVT, if it is a provoked DVT, 3 months. If it is non-provoked, first DVT, 6 months. But we know there are some special cases with recurrent DVT with pulmonary embolism. We always approach our hematologists. So, and maybe some cases they need lifelong. If there is a recurrent DVT, if there is an ascending DVT, it depends on the case. But normally, also in a nivel, 6 months, because we know after 6 months the stent is endothelialized.
Thank you. We should open it up to the audience. Any questions?
We have a question from our audience, Professor Sunatov.
Сэр Джалай, прекрасный доклад. С вашего разрешения у меня следующие вопросы. Первый вопрос – это доступ имеет значение или нет? И второй вопрос. В вашей работе ретромбозы встречались? И если ретромбоз, какова тактика? Вы применяли тромболизисную терапию или нет? И следующий вопрос. Временный кава-фильтр нужен в таких случаях или нет, если острый тромбоз? И четвертый вопрос. По вашей классификации, сейчас мы увидели первый, второй, третий тип. Если четвертый, пятый тип, у вас объем операции меняется или нет? Спасибо.
I hope Lowell or Ram are going to translate it for me a little bit. Or Kathleen, do you have a translation or we will receive a translation?
Первый доступ был. Вопрос доступ. Переведите, пожалуйста.
There's a translation on your Zoom.
Okay. The first question was about approach of your treatment. So what approach do you use?
So in acute DVT, if it is within the 2 weeks, really within the 2 weeks, we go for the Jedi thrombectomy device, which is now Abbott, because it's very flexible. I can, even from the ipsilateral approach, from if patient is in prone position, we go transpopliteal, I can go into the deep femoral vein and I can clean also collaterals if it is an acute or chronic. But it doesn't work after 2 weeks, mainly on 3 weeks or subacute thrombosis. Then I take clot triever. So that is my regime. And I clean as much as possible on table. Sometimes in some patients, we need additional catheter-directed thrombolysis only for 1 day. And the next day, we see if everything is cleaned and then do the stenting and hopefully discharge the patient a few hours later or day after, under anticoagulation and compression study. And we have a very rigid post-op approach in all acute and chronic patients. First follow-up is 2 weeks, 6 weeks, 3 months, 6 months, 12 months.
Okay, thank you. So we
Спасибо.
have. Thank you.
Yes. Lowell.
So now I will introduce Kursat Bozkurt, professor. He's also a member of the executive board of Vein Lymphatic University and is in charge of our humanitarian project. And he's going to be talking about when do you prefer cyanoacrylate over thermal ablation? Kursat, you're on mute.
Okay now? Do you hear me? Lowell, okay?
Yes.
Lowell, do you hear me? All good?
Yes,
Yes.
we
Hello,
hear
do you
you.
hear me?
So go ahead. Thank you.
Yeah. Right. First of all, thanks a lot for the kind invitation. Unfortunately, this year I can't join you because our national meeting was very close to yours. That's why, sorry, I couldn't come. But you know, my heart is with you. Definitely, there's no question about that. Right. In reality, there are two important cyanoacrylate devices in the market now, Benebloc and Benecil. The difference between them is polymerization time. The polymerization of Turkish glue is definitely less than American glue, and it makes some advantages for us, and it makes some differences for the usage of this material. Now you can see the typical Turkish glue in seconds, in really seconds. You can easily see how strong is and how fast is the polymerization of Turkish glue. The question I have been asked is, when do you prefer cyanoacrylate over thermal ablation? There are several indications which I'd love to use glue instead of thermal techniques. First of all, patient preference. There are some group of patients, they hate needle sticking. they have some needle phobia, and because of the tumescent anesthesia, they hate of it. And if the size of the vein is 12 millimeter, and if the patient wants some sort of needless technique, we can just easily proceed with glue. Allowed to use below knee long saphenous vein because of the nerve damage business. And also, I usually like to use glue for the distal short saphenous vein, again for neural damage possibility with thermal techniques. I will show you some slides about perforating vein ablation. And it's my routine now to use perforating vein ablation. I also like to use for radio cases and long time following the surgery or thermal ablation. These are my preferences for Turkish glue. There are some slides here. For example, if distal long saphenous vein involved, I just like to go with glue. And also sometimes short saphenous vein and Giacomini vein problems allow to use glue instead of thermal techniques. For example, in the right picture, you are very close to the nerve here, and you may easily glue here. This is a very important case. I did radiofrequency ablation several years ago, and the patient started to have some complaints. Okay, doctor, why it happened? Why this vein stayed open? Am I responsible? Am I going to pay again for another procedure? For this patient, it's very easy to do glue plus foam ablation. In the clinic side, you can just simply put a cannula just below the subfemoral junction, put some glue there, and for the rest of the vein, you can do foam ablation. I can guarantee you it's going to be as effective as thermal ablation techniques. This is a patient with Klippel syndrome, and there are big major channels here. You can see for the big major channels, you can easily use glue ablation for this patient. And in some patients, I do mixed procedures. I combined glue and laser techniques. Definitely specifically for Klippel patients, it works very nice. And also, don't forget, if you are doing glue instead of thermal techniques, the possibility of glue ablation is less. And if some patients want one stage, I just go to ablation. And the major thing is perforating vein ablation. I presented this data in VT this year. For perforating vein ablation, we routinely use glue ablation. Under ultrasound examination, you are putting the needle just above the fascia, in the level of fascia. Like here, you are putting the IV cannula, and you are just injecting 0.5, 0.6 of glue for closure. And it works, it really works for perforating ablation. There are several pictures you can see here, and almost all of them, the perforating vein was closed. Again, another case. This is very interesting case. The patient was bedridden because of serious problems. She was in the bed for months, and she started to have heavy bleeding. And there was a big perforating vein just here, and we did again glue here. You may think the possibility of infection and permanent stuff inside it, but glue have some properties, bacteriostatic properties, and it's not going to be a problem. This is our results in 12 months. As you can see, almost 90% closure rates with using a glue, and AVVQ is getting better. There's one big study published from Turkey. One of my friends did a glue ablation for perforating vein for almost 200 patients, and definitely it worked very well here. So the answer is yes, in some cases, we like to prefer glue ablation for thermal techniques, and thank you a lot.
Thank you, Kershak. I would like now to introduce, as a discussant, Professor Maj Joel of Cambridge, England.
Oh, thank you very much. Can you hear me, Lowell?
Yes, very well.
Fantastic. So I'm going to make a couple of comments. First of all, I agree with everything that Kujat has just said. And actually, we are very fortunate at the moment to have so many excellent options available to treat our patients with venous disease. That's the first comment I'd make. I think that the non-thermal approach has significant advantages and properties, but interestingly, thermal ablation is what I use for most of my patients. And the main reason is that in my country, the cost of the glue is a bit more. So I think case selection is very, very important. For our practice, it's the multi-segment and the very distal below knee treatments that are particularly good choices. The avoidance of that nerve injury is very, very important. And the final sort of just brief comment I'd make is just about training, and is about getting very comfortable with the techniques that you use. It's a confusing space at the moment. There are dozens of different thermal options, dozens of different non-thermal options, and I can imagine it being quite an intimidating place for a new physician to pick up the techniques. I think what is more important than the specific technique is to be very good and confident in the technique that you use in your hands. In my practice, I have a thermal option, a non-thermal option, bone sclerotherapy, which is very versatile, and of course, the option for open surgical intervention and phlebectomy. But the final comment I'll make is my prediction is in 20 years' time, we will be mainly using non-thermal treatments. Now, what that will be, I don't know. I'm not saying it will be glue, but I think non-thermal will be the answer 20 years from now. So you can record that if you like, Lol, and play it back to me.
Persat, any comments?
I totally agree with management. I totally agree. In not 10 years time, we're gonna move to non-thermal techniques. Not 10 years.
Thank you. Now to our audience participant, I would like to introduce Elena Merzina. Sorry for the pronunciation, but the floor is yours.
Hello, dear colleagues. Hello, Professor. And I want to ask you about your comment, please, on the discussion about the risk of mortality in patients after glue treatment, and dispel these rumors, please.
I mean, it was a bad paper, though. I mean, they published 19 deaths after glue procedure, but unfortunately, almost all of them related, not glue related deaths. For example, one of the patients died because of septicemia, but the patient refused to do any kind of treatment. So every procedure, including foam, including laser, including radio frequency, do have some sort of very, very short mortality risks. I know until now, 1 million patients did have glue ablation procedure, and there are only 19 reported deaths. Actually, none of them really related to the glue. The only thing we have to question is regarding the allergic reactions for glue. It's in American series 3%, in our series less than 1%. This is the only concern should be for the glue. But I mean, increased mortality is totally, it's nonsense.
Thank you. And if it's possible, I want to ask you one more. About your secret to avoid granulomas according your technique to multiple puncture of vein.
So in our series, I mean, I have the data overall. I mean, I haven't done 300, 400,000 cases, but I have all of the complications with using Turkish glue. We don't have any reported case of granuloma after Turkish glue. There are some granuloma formations in the exit site. If you not injecting any glue at the exit point, we haven't seen any granuloma formation with using Turkish glue. So it's very important. You have to stop injection of the glue 2 centimeters away from the saphenofemoral junction. Sorry, exit site. So otherwise you are safe.
Thank you, Professor.
I'll turn it back over to Evgeny.
Yeah, thank you, Lord. And our next presentation from Argentina, from Javier Calatayud. What is the sausage technique, benefits and risks? Please.
Very grateful for invitation to share technique, especially to St. Petersburg Society of Phlebology and Dr. Lower Kamnik. Why sausage name? Because they, for example, look like a sausage between two rubbers ligatures. With difference, two rubbers ligatures, dense form and trendelemma. Two rubbers ligations, first on ankle, trendelemma, and a distal ligation on knee. We use a personal tourniquet, homemade from a tube, a rubber band, and a clamp. Variation in diameter of vein with trendelemma rubber ligation, a reduction about 30% after rubber ligation and trendelemma. How work? Sausage technique: less foam runoff, less foam injection volume, more contact form and less vein blood. Amount concentrations is important. The personal clinical experience. Sclerotherapy in artisanal. Sclerotherapy is an artisanal technique. Yes, sclerotherapists have to find a personal result. Note about the sclerotherapy in Argentina, polydocalor concentration is between 0.25 to 8%. If a session is not effective, only need more sessions. Useful for treat recurrence and useful in great vein diameters. Technique: first ligation on ankle, trendelemma. Second ligations, injection, wait, and tie the ankle ligation and ligation near the groin. For example, for infrapatellar saphenous vein, rubber ligation in ankle, trendelemma, ligation on knee, injection, and tie the ankle ligation and ligation very near the groin and inject. For back position, the same technique. For section treatment, the same distal ligation, trendelemma, and a proximal ligations. Injection control is very important. Pre-injection, we can see the vein diameter, and 5 minutes later we can see the vasospasm. Form, we use 1/8 air form or ozone sclerosal ratio. We try to use glass syringe. With this form, we describe a scene like called chessboard scene. Post form, we try to bandage. What happened when we release a rubber ligation? We don't have a lot of amount of form to the deep veins. Result, we have a very good result, no thrombophlebitis or very less, no sclerus. For example, in this patient, a 40 millimeters vein aneurysm, very near the groin, 40 millimeters. And 1 month later, after only a session, we can see only 2.59 diameters of a treated vein. More result. In some case, we need more than one session. And conclusion, no DVT, less thrombophlebitis, less sclerus or very short sclerus, less pigmentation, not for newcomers. Try first with traditional foam technique. Thank you.
Thank you very much, Javier. Very interesting presentation. I would like to introduce our first discutant, Carlos Carbajo from Brazil. Carlos. And from our audience, Sergey Belintsov. Sergey, please.
Hello, my dear colleagues. It is very interesting experience in foam sclerotherapy, and ultrasound-guided foam sclerotherapy is widely known method of varicose vein treatment. How many days do you recommend to use compression stockings?
I only use a common bandage or 35 to 40 millimeters stocking.
For how many days? So for how long?
A month.
Months. Okay. 1 месяц.
1 месяц, да? Хорошо. Все? Нет больше вопросов? Thank you. Thank you very much. And Carlos, with us or not? Okay. Thank you very much again. Kathleen?
Yes, thank you. So the next presentation is why are we not seeing improvement in leg ulcer care, to be presented by Professor Sriram Narayan.
I hope you can see my screen, guys, and you can hear me.
Yes.
Thank you. I'll just take the show from the beginning. All right. Rather than much of a scientific question, this has really probably become a philosophical question in my view, and so I shall present it with bits of science and bits of what I think. We know now from science that chronic venous ulceration means there's a high ambulatory venous pressure at the ankle. We know that the condition causes chronicity and leads to chronicity within itself. We know that there are lymphatic components that need to be addressed. So the science is caught up in many ways. We know that it could be from primary incompetence. We know that post-thrombotic syndrome could be a cause in many of these situations. We are learning how to manage them with interventions. We know which combinations of veins are involved and how often. But we never tell each other the truth about why these ulcers seem to carry on and on and on, despite all these advances that we've had. And historically, ever since the Egyptian papyruses from so many years ago, we have sort of concentrated on the superficial venous system and gone around in circles trying to sort it in various different ways. So you have the ulcer bowl, which is still preserved at Charing Cross Hospital, where I trained, the 4-layer compression bandaging, we've had high tie, sclerotherapy, endoscopic perforators came up and went away for some time, and all the endovenous ablations. And ever since the turn of this century, we have started endovenous ablation. All sorts of various devices have come out. We all swear by them, and it has become a wonderful business. Unfortunately, they also, as part of this business, advertise legs like these on their websites, which have nothing to do with serious chronic venous insufficiency. And the only person who seems to be doing well is the vascular surgeon, but not the venous leg ulcer. Because this is the reality in our clinical practices, that the disease seems to progress despite all that we do, and once the ulceration occurs, it comes and goes and comes and goes, and sometimes, unfortunately, leads to malignant change. If we look at these results of the first of the trials that was looking at a combination of conservative and surgical intervention, we will find that you have 89% healing. Can we hear, or is there an echo?
Everything
Yeah.
okay?
So we've seen, yeah, okay. So we've seen from these early trials that in a trial scenario, we're getting 89% healing at 3 years with conservative therapy, 93% healing with conservative and surgical interventions, but none of us seem to translate this into clinical practice. Why is this working in a trial scenario, giving these crazily good results? But in reality, in our clinical practice, the results from Copenhagen and Colombo are probably the same in terms of long-term ulcer healing. Why are we not translating this into long-term healing? And then, of course, we have all these advertisements. We play around with various types of ulcers, with various types of dressings, when the primary problem is not with the dressing, but the understanding of the disease. So our approach has been, we first try and seek superficial incompetence and hope there's no deep venous disease unless you're Human Jalai. If you do find it, you fix it with a stent, and then we all try to find a better stent. We use a cocktail of very expensive wound care products, all of which seem to promise perfect healing, but doesn't quite happen. And then we get compression, 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 and when we get bored of doing compression, we find somebody else to do the compression. So if there's a patient with a chronic venous ulcer, first you delegate. You get somebody else to see the patient, preferably your registrar, your SHO, or somebody else. And then you relegate. You move it away to a different clinic, a nurse clinic, a peripheral clinic, a community clinic, so you don't have to see the ulcer. And then finally, you start finding fault with everybody. You find fault with your registrar, you find fault with your patient for wearing stockings for too long. If they say they don't wear stockings, and you say, why don't you wear them? If they say they wear stockings, you say, why do you wear them? And we keep finding fault. But the true word is hate in this whole management of venous ulcers, because we hate the fact that our patient keeps coming back. We hate the fact that our general practitioners send them back. They hate us because we seem to be doing nothing as clinicians. Our nurses and staff and junior residents find us irritating because we keep finding fault with them. And the patient hates everybody, including themselves, because they're not healing and they hate the way their leg looks. And finally, you look at yourself in the mirror and you hate yourself because you're not finding the solution that you need. And this is probably what's new Now we understand the pathophysiology. Our own publication 5 years ago on the physiology of venous return. We know the anatomy. We have so many technical advances. But what is not new is that we do not own the patient. And that, I think, is the primary reason why a trial result is so much better than in clinical practice. We have refused to take ownership of the venous leg ulcer patient. And I believe that single clinician ownership of a patient is the key, just like you have an aortic aneurysm. If you have an aortic aneurysm, it is your outcome, it is your rupture, it is your type 2 endoleak, it is your recurrence. Just like if you have peripheral arterial disease and you're intervening in that, it is your amputation, it is your limb loss. But if your ulcer does not heal, it doesn't seem to be your failure to heal the ulcer anymore. The whole system appears to be at fault. I find that when I was the professor at a university hospital and I have about 20, 30 people, 14 wound care nurses, a whole team with me, my ulcer healing rates were worse. Now I'm all by myself with 2 nurses and I see every patient in my private clinic. My ulcer healing results are better because now the patient finds fault with me if I do not get that ulcer to heal. So I think we have to understand that while the condition is progressive and we all have the clinical knowledge to do things in various different ways, the elephant in the room is this: somebody needs to take ownership, and you probably need to start having a league table. And we as clinicians dealing with venous ulcers need to deal with it as venous ulcers and not with middlemen, not like middlemen who keep trying to transfer who actually does the interventions. And as long as we get our endovenous money, we don't care more about the patient. So like you would with an aneurysm or a peripheral arterial disease patient, you need to take ownership of that ulcer. We probably need to have league tables of healing outcomes for various clinicians. And we should not distribute the responsibility for the failure of an ulcer to heal into a system. We need to take ownership. Venous leg ulcers are a medical problem. You should not share the blame with allied staff, with health systems, with nursing, that patients don't know enough. So if we really want to improve venous leg ulcer care, I think the first step among us clinicians is to take personal responsibility to see that that ulcer heals, which is why ulcers in trials heal, but ulcers in practice do not. Thank you, and it's a pleasure to be there.
Next, we'll invite Dr. Ruth Bush to discuss this excellent talk that was just given.
Thank you all, and thank you, Vein and Lymphatic University and the St. Petersburg Venous Forum for this opportunity. Dr. Narayanan presented a very nice comprehensive overview of venous leg ulcers. We know that venous leg ulcers are multifactorial. They come from a variety of different etiologies. They may include arterial disease as well as systemic metabolic conditions. Dr. Goel, who's on this session, and his colleagues published in 2007 in the ESCAR trial that VLUs healed better with compression and surgery at 3 years. But I would say 3 years is a long time. That is post-intervention, whereas patients may have had the ulcer for multiple years prior to that. We've also seen, and Dr. Narayanan presented, many dressings, biologics, honey, fish skin, human cells, to deliver growth factors, antibiotics that may help, but still we have venous leg ulcers that are refractory. In 2010, a group of vascular surgeons and phlebologists did a call to action, calling for the calling for the reduction of venous leg ulcers by 50% in 10 years, by 50% in 10 years. Here we are 15 years later, and we are no better. We are no better. Do we need another call to action, Dr. Narayanan? How do we build a global, achievable plan? We have prevention tools. We have educational tools. We have excellent treatments, as you outlined. So what are the new critical issues? What is a reasonable action plan? The American Venous Forum and VLU are a global organization with visions to promote venous and lymphatic health. How do we move this needle? How do we improve venous leg ulcer care? And it's not just the care, it's the healing. That's what makes the difference to the patient. So do we need another call for action? We have not seen a 50% decrease in venous leg ulcerations. In fact, I would say we have probably seen an increase, even though our knowledge is so much more. So I welcome any types of scenarios, any type of updates where we may work as a global community as we are this morning. Thank you for the opportunity to comment.
Thanks so much, Ruth. A pleasure to connect with you again after Amsterdam. My first answer to that would be in this call to action. Let us round up all the vascular surgeons and clinicians who actually made the call to action in 2010 and ask them, besides writing a paper and making a noise about it, did they actually improve their own ulcer healing in their clinic? And why did they not? I think it's important, and it's come to a point, given that venous leg ulcers are such a huge drain in terms of cost, effort, and time and resources on healthcare systems. It is not cheaper to delegate it to nurse care, to multidisciplinary teams, and send it far away. It is probably cheaper to make it heal under your nose. So I personally think, whilst we have tried all sorts of techniques and the science is very well known, I think somehow we might have to bring a shame game into this. We have to probably say Dr. Human has got a 90% healing rate, and Dr. somebody else has a 63% healing rate, and that should start going up on websites. We need to start taking personal responsibility. We should stop having people putting these wonderful legs on their venous websites. And we need to start putting reality figures on the website. Perhaps the shame game will work, because certainly the call to action has not.
Thank you.
Kathleen, we change our discussant from the Audi. Yes. Елена Мурзина, please.
Thank you very much for sharing your presentation, for your complex approach. Of course, it's a way of success because often we don't see the effect of ulcer treatment, despite the fact we follow the algorithm and clinical recommendation. And of course, the complex approach, it's a way for success. Thank you.
I have to admit, I am not sure I got all of that question. Could somebody who got it reiterate it to me?
No, thank you. Thank you. It's no a question. It's words for thanks for you.
I haven't quite got the question, I'm afraid, because of echo and this and that. Seram, so it was just words of, so congratulations with a highly important work, so there was not a question inside of this talk. And I also want to congratulate you with this nice paper about arterial venous ulcers, where you also was an co-author. So.
Thank you.
My dear friends, Lowell, colleagues, it's a great honor for us to hear from the leaders of the world phlebology from different countries. I think your fantastic presentations very helpful for our leaders of our phlebology, new generation of phlebologists in their daily practice. So our congratulations with Thanksgiving Day, and congratulations with the fantastic section of the Vein and Lymphatic University. Thank you very much. See you in the nearest future in different congress in all the world. And the nearest One American Venus Forum, I think so.
Before we sign off, I'd like to thank you and our colleagues for a wonderful session. And we wish you Merry Christmas and a Happy New Year. Thank you very much for the opportunity.
Thank you very much. See you soon.
Thank you.